Vice Chancellor and Father of Medical Laboratory Science, Federal University Otuoke, Professor Teddy Ades, the Deputy Vice Chancellor and Chairman of the occasion, Professor Chris Onyema, the keynote speaker, Professor Musa Abidemi, the convener of this maiden occasion, Dr. Agoro E.S., the deans of faculties, the heads of departments, the professors, distinguished colleagues, researchers, and guests. It is with utmost sense of joy I welcome you all to this maiden annual conference of our great Faculty of Medical Laboratory Science, Federal University of Otuoke Bayelsa State. History is being made today as we play host on the occasion of this maiden conference tagged Film Reading. The theme of this maiden conference is Unlocking the Potentials of Film Reading in Laboratory Practice and Research. This is apt as we explore the intricacies of film reading for diagnostic and research purposes, honing our skills and appreciating the place of modern technological trends in film reading in our various fields is the focal point of this conference. As we are gathered here today to share knowledge, exchange ideas, and collaborate on cutting-edge research in the neglected field of film reading, I'm convinced we shall all together be fronters in championing interest in improving disease diagnosis and research through film reading. I'm confident that this workshop will be a platform for fruitful discussions and innovative discoveries, as we are aware that science thrives on collaboration and communication. I encourage everyone to actively participate, ask questions, challenge ideas, and most importantly, learn, network with one another. I therefore just to utilize this opportunity to push the boundaries of our understanding and make a meaningful impact in our field. Being a maiden conference, there's a possibility for a few shortcomings. Therefore, we're enjoying to avoid the temptations of being distracted and rather remain focused on the major reasons why we're here. Thank you all for being here, and let's make this workshop a tremendous success. Aloha. Ndewono.
A round of applause, please. Thank you. See, one wonderful thing I know about medical lab science, I know that even God is a medical lab scientist, because they told us in the Bible when we are growing up that at the last day, now they will view you through, it will be like that the God was viewing you through your mirror and be seeing all the sins you are committing. That's film reading. So, you know, this is a group of people that are surrounded by beakers and all those. So, and you guys play with blood. I don't know how you manage it. When I see blood, I get scared. But usually handle blood like if you are talking about blood money, you guys should be the richest. Okay, at this point in time, I want to welcome to the rostrum the acting dean to come and give his address.
Thank you very much. The Vice Chancellor of the University of Otuoke, standing on the existing protocol already established by the Chairman Organizing Committee, no one can withstand a determined mind anchored on sincerity and selfless purpose. I first give thanks to the Almighty God for the grace of life accorded me and members of staff of the Faculty of Medical Laboratory Science and the University at large. Queuing to this is an appreciation to the Vice Chancellor of Federal University, Otuoke, Professor Teddy Adias, Charles Adias, for appointing me, this small boy, the acting dean of the Faculty of Medical Laboratory Science, and attendant enormous privileges, leverages, facilities in the faculty. I am full of joy as I welcome you all to the maiden edition of the Conference of the Faculty of Medical Laboratory Science. The maiden edition is tagged Film Reading Workshop with the theme Unlocking the Potential of Film Reading in Medical Laboratory Practice and Research. This workshop was born out of the dwindling critical role of film reading in disease diagnosis, management, and research. A lot of diseases cannot be diagnosed accurately without the inputs of film reading. Despite this crucial place of film reading in the practice of medical laboratory science and other fields of study, the tool is on the utility decline due to breach, stroke paucity in expertise and technical know-how. The gap resulting from the analytical space of film reading bettered this workshop. The faculty gathered best hands on the bench and classrooms to form the nucleus of the research persons for the workshop. The keynote speaker, Professor Musa Abidu Muhebi, and other resource persons are known for their depths and grasp of knowledge in the field of discourse. I charge all participants to sit tight and glue as our resource persons open up the atmosphere of film reading with massive scientific inspiration and insight. In a similar vein, awards will be given to selected staff for the enormous sacrifices coordinating to the successes recorded during the curriculum program design, NUC, and Medical Lab Science Council of Nigeria resource visits of the Medical Laboratory Science program. These great men and women of honor worked tirelessly to ensure that Medical Laboratory Science program saw the light of the day. And indeed, the light is here, and we all can see it clear. As an active player of the process, I pray God bless you all with the best of rewards. However, kindly accept the little gifts from the members of the staff of the faculty. Again, I welcome you all. Balwa. Thank you.
Thank you, and God bless you. Without wasting our time, it's my honor to invite to the rostrum our chairman of education, the amiable Deputy Vice Chancellor of this university, Professor Chris Onyema, to come and give his address.
The Vice Chancellor of the Federal University of Otuoke, the very distinguished Professor to the Chasadias, the Dean of the Faculty of Medical Lab Science, Dr. E.S. Agoro, on acting capacity, the keynote speaker of this MAIDEN conference, the organizers of this conference, the presenters, colleagues, distinguished guests, ladies and gentlemen, I have been asked to serve as the chairman of this occasion, and I must tell you it sets me on very uncomfortable ground, knowing that my Vice Chancellor is here. I don't know whether the Dean wanted to deliberately set me up. When I also looked at the items on the program, I was happy. I had no clearly defined role, apart from to sitting there as chairman. But since I must speak, I might clearly take the permission of my Vice Chancellor to congratulate this young faculty of ours that is eventually not so young. This blessed faculty of ours that prides at having the chief executive of this university as its member. This faculty of ours that has, in such a short period of its existence, already pioneered two public events that are actually outstanding. A couple of weeks ago was about administrative positioning and recalibration, when the immediate past dean of science, Professor Mrs. Ihoma Dekole, was called upon to speak with the faculty on how to properly administer a faculty. When I saw the poster, I was humbled and I was reassured that the acting dean of the faculty was surely on the right path. I believe that having laid the proper administrative foundation, the faculty now saw the need to tell the world that it has arrived. And that is the essence to me of this very important workshop that focuses on what is actually germane to the business of the faculty, which is unlocking the potential of film reading in laboratory practice and research. In view of all the constatations of superiority among specialists and professionals in the medical profession, none has actually taken away the specialist assignment of film reading from specialists in medical laboratory science. So, to call for a workshop that clearly establishes this dominance in the field of medical practice is a thing that must not go unnoticed. I therefore congratulate my Vice Chancellor, under whose administration the Faculty of Medical Laboratory Science was established. I thank again for the forthrightness at which he appointed the management of this particular faculty, ably led by an acting dean, Dr. E.S. Agoro, with the likes of Professor Jeremiah lending experience and maximum support. Here is hoping that by the end of this the end of this workshop, as a matter of fact, for me, a workshop is more technical than a conference. We are not expected to come out at the end of the day with resolutions. It is at this stage that communique is actually practical in nature and very ready for implementation. Here, professionals test their practical skills and cross-fertilize ideas on how to improve their potentials in this particular field. So I congratulate the presenters. I thank the faculty for this initiative and hope that by the end of this workshop, you will come out with positions and experiences that will not only further your practice in this particular field, but also be a blessing to humankind and bring development to our dear university. Again, I thank you very much for this opportunity. You are welcome. God bless you.
All right. Before we go on to the next item, I want to bring to the high table the Dean of Social Sciences, Professor Lule, please, to the high table. I intentionally kept a certain recognition for the right moment. I know you cannot talk of medical lab science without talking about blood transfusion science, without talking about histopathology, so cytology, without talking about chemical pathology, without talking about medical microbiology. I want to recognize the head of departments of blood transfusion science, that's Department of Hematology, stroke blood transfusion science. Dr. Emmanuel C. Onoaha, please wave your hand. Thank you. Also, the Department of Histopathology stroke cytology, Dr. Ebuka Ajanwachuku, please. In the same vein, I recognize the presence of the Department of Chemical Pathology, Dr. John Ifenkwe. The last but not the least, somebody of like him. In fact, maybe after saying this, I don't know what will happen next, but they have the best of species, the best of everything, the university. They are number one in the university. I must say it. So sorry, sir, no best for me. So at this point in time, I want to invite the chief host of this event, our own Professor Teddy Adia, the Vice Chancellor of this university, to come and do his thing. Please, may we rise. Please be seated. The chairman of education did my small deputy vice chancellor, Professor Christopher Yema. And I came in, he said, "Can I wear my cap?" I looked back and said, "Are you not the chairman? Put on your cap so that you can be well decorated." And I saw him shaking.
He repeated what he told me while we were seated during the course of his opening remarks, and I noticed that he did not conclude it. As chairman, his responsibility will be to declare the occasion open. I wonder why he skipped that. But the temptation have been made by Professor Agoro, even though he is not a professor now. I want to welcome you again to our university. Paul, at several times, has dual nationality. When things are in crisis, he looked at the environment, you will say he's a Roman. When he's held by the Jews, you will say he's a Roman. When he's held by the same Pharisees, he will remember to tell them that he's a Pharisee. And today I'm bold to say that, yes, this is my faculty. At the point that we are seated here today, we count at least the existence of 5 faculties of medical lab science.
Award, and it shows that hard work really pays. And I also want to thank the Almighty God for making it possible for me to be in your midst today. Thank you very much.
Thank you for thanking us. I am sure that apart from the academic members of the academic community in this university, who knows that the acting dean is called the chief priest. And you see, when you now marry the two together, blood transfusion, chief priest, it becomes scary. Chief priest, thank you. At this point in time, we are strictly following the program of the day, and we are coming close to the end of this session. I'm going to invite the keynote speaker, the keynote lecturer for this epoch-making event. Keynote. Yeah, the keynote speaker. Okay. And that is Professor Musa Abidemi Muhibi. Professor Musa Abidemi. You can take a seat over there. Ushers, ICT, please, can you come and clear this table? I mean, the chairs here, so that the movement on the high table. Okay, so I'm inviting Prof. Inviting Professor Musa Abidemi. Okay, you're welcome, sir. And then to read the citation is Dr. or MLS Mordecai.
My amiable VC, the chairman of the occasion, all protocol duly observed. I have the privilege to read the citation of our keynote speaker, Professor Musa Abidemi Mohibi. Is a fellow of both Medical Laboratory Science Council of Nigeria, MLSCN, and West African Postgraduate College of Medical Laboratory Science, and a bioethicist trained through EDCTP grants. He is a faculty member of Foundation in Laboratory Leadership and Management modules, as designed by Association of Public Health Laboratory towards strengthening African laboratory managers and administrators. He participated as an assessor in the Laboratory Need Assessment of National Medical Laboratory Strategic Plan conducted in the year 2012, and was a member of the Technical Working Group and prepared State Strategic Plan on HIV/AIDS for the state of Osun 2010 through 2015. He was a co-chair of a committee that prepared blood transfusion guidelines and standards for National Blood Transfusion Service in the year 2022. He has been a member on the Future Leaders Mentorship Fellowship of American Society for Microbiology since 2022, and one of the few Africans on that list. He has received several awards, among which was an award of UNESCO MEC in Switzerland during the maiden edition of MEC African Research Summit in 2015. Interest Conference in 2019 as an abstract presenter and participant in Ghana, and TETFON Research Grant on the study of a neglected tropical disease. He was awarded the Silver Plus Award by National University Commission, NUC, for participation in the review of accreditation tools in 2019. He has published more than 76 scientific articles in reputable journals, authored 3 textbooks, all in the field of hematology and biomedical research ethics. He was a facilitator on Global Health Network Series, EDCTP, supported project, University of Oxford, in collaboration with Osun State University, 2020. He served as a receiver, K4 Health/Nigeria CPD program, John Hopkins Bloomberg School of Public Health, USA, 2015 and 2016. Professor Mohibi served as external examiner on hematology to some Nigerian universities, including Usman Danfodio University, Sokoto, and University of Ibadan. He belongs to many learned societies, and he is the Secretary General to Hematology and Blood Transfusion Scientists Society of Nigeria, as well as Regional Training Coordinator for Hematology Faculty of WAP-CMLS. Professor M.A. Muhibi served as the chairman of AMSIN Emergency Response Committee on COVID-19, a volunteering position through which his team filled an appreciable gap in the fight against COVID-19 pandemic by producing in-country viral transport medium, which was used by some states across the country. He was the National Secretary of Association of Medical Laboratory Scientists of Nigeria and the Secretary to the Society's Board of Trustees. He is a professor of hematology and the immediate past dean of Faculty of Applied Health Sciences in Edo State University, Ozario, Edo State, Nigeria. I hereby present to you our keynote speaker for today. Thank you very much, Prof.
The Vice Chancellor, sir, I want to seek your indulgence to permit me to extend the established protocol. I don't just want to adopt the protocol like that. And the extension will be by stating the fact that I have here in this hall my mothers. Don't look at the agenda. Those who provided motherly care for me, starting from the Vice Chancellor himself. While he was giving his speech today, it reminded me of how Professor Charles Teddy Adias explained instrumentation and automation to us in Rivers State University in 2005 when I was a PG student. It reminded me how he taught us immunohematology. So one's not surprised when you can't few professors of immunohematology across the globe, you cannot miss the name, Professor Teddy Adias. Thank you, sir. The Vice Chancellor and the Chairman of the occasion, my teacher, supervisor and mentor, who is also here seated. Incidentally, that is the President of Hematology and Blood Transfusion Scientists Society of Nigeria, Professor Sakios Awotu Jeremiah. Since I have adopted the established protocol, I only extended it, and with the permission of the PC, let me continue to speak to the slide. Thank you, sir. Today, I'm delighted to be here to discuss this topic for minutes, one of which is the fact that I am standing before my teachers and respected colleagues. When I had similar opportunity to give a talk in UI, Faculty of Basic Medical Sciences, where I trained as an undergraduate, I was this delighted too. So I appreciate you once again, Mr. Vice Chancellor, and specifically I need to appreciate the Dean of the Faculty of Medical Lab Science, the convener. I appreciate you, sir, the Dean. We want to look at potentials of film reading in laboratory practice and research. Well, by way of introduction, we follow this outline. Okay, yeah. So we look at this as our background. Because as we are seated here, you can see ourselves. One can assume that those looking at you are those you can see in this hall. But if you are a proficient film reader, you can apply your skill to see beyond those who are in this hall. Because you will apply the most current technology to discover that some people are watching you even online. So that is what we want to look at. And this is the outline we follow. Who's going? Okay, yes. Film reading is actually a cornerstone of laboratory practice. And the process of film reading involves meticulous examination and interpretation of images that are captured through imaging modalities. So many. Those that are relevant to medical or biomedical science will be the use of microscope, the use of digital morphology. Even if you are a radiographer or radiologist, you read film. If you are a photographer, you read film. But for us in laboratory science, we limit ourselves to microscopy and digital morphology. We use microscopy and digital morphology in biomedical science for diagnostic purposes, for research, and that is reflected in the topic. Beyond that, yes, next slide. To be able to look at the film, you must be skillful at it. And to acquire the skills, you must have been trained. And you must have been trained and you must have acquired the skill to an appreciable level such that you must have been certified, especially when it comes to the field of medical lab diagnosis. Notwithstanding your level of proficiency, you must continually be subjected to training. And that is why the prerequisite for licensure is that you must have 10 units CPD previous year before you get next year license. Because the field of medical lab science is so dynamic, very, very dynamic. I thank God that from what I've heard today, maybe the Faculty of Science gave birth to this faculty. I can see many awards given to our mothers from Faculty of Science. Actually, bringing science to medicine, that is medical lab science. Yes. So, you need skill that cannot be replaced with ordinary machine. And before I continue, I want to remind us, the field of medical lab is evolving. You will recall that sometimes around 2002, 2003, if you open a lab where you use 3-part hematology analyzer, you will pride yourself, your shoulder believe that yes, in our lab we have automation. 2003. This is 2024. If you have 3-part hematology analyzer, are you now, can you shine with that one again? You can't. Somebody is having 7 parts, you are having 3 parts. A machine that will lump together monocytes, eosinophil, and basophil and call them cells. That cannot be a thing to be proud of in 2024. Even with that, whether 5 parts, 7 parts, 3 parts. I worked one time in a teaching hospital and research lab, a diagnostic research lab, and sample was sent to our lab as a workup, as a background for this, for see the reason why we stand as far as scientists in imaging. The sample was sent as a workup for patients that were prepared for money. They wanted to remove one bed of the baby because they think that the bed was just when some of the operation boxes have been taken. There is no malignancy. That means you say it's a benign tumor. Before the person is to work out. So that doesn't respond and do what body. That was a good decision. But after they said, okay, but what the woman did prepare for the giving the organ. And we had in that lab, the 5-part hematology analyzer, that tell us the 5 components of white blood cells in terms of quantity. and percentage, proportion. But we not tell us the morphology of the cell and many other things that can be seen from blood film. As a policy of that lab until date, even when you use automation, you make your team film. I was the unit head of that lab. It's a policy. You cannot report FBC without making film, even when you have the so-called highest technology of automation particle counter. From the film, what we saw, you will see it later. We saw what you call Ucherera bankruptcy. Ucherera bankruptcy is a microfilaria that can infiltrate soft tissues of the body and make it swollen. And one of such targets is the breast of a woman. Numerous bankruptcy result was reported, including what we saw from reading. The surgeon decided to treat that woman first for microfilaria. If there was no deliberate approach of examining and reporting what was that woman would have lost her breast. They help you to remove your breast in the constitution. So these are the area next, and I've added data morphology there, which we are going to discuss briefly, and AI, application of AI, artificial intelligence, in film reading. We're going to look at that. Well, the strength or the addition, the beauty that our film reading skill will bring into the practice of medical lab science is that it will help us. So we use power of visualization, we have enhanced diagnostic accuracy. It will help us to enhance what is called precision and accuracy. For instance, precision, reproducibility. That the result is reproducible does not mean it's accurate. If you are using wrong method, you can be getting the same wrong result. That is precise, but it's not accurate. And so you need both precision and accuracy, and from film reading you're able to do that. And when we have precision accuracy, you're able to determine what is called positive predictive value. If you are comparing a protocol, a procedure with already standardized procedure, okay? We need to know that in diagnostic medical lab science, we don't just perform experiments. That's the difference between medical lab science and other laboratory-based sciences. In medical laboratory science, we don't just perform experiments. We carry out standardized, validated experiment. Validated. If you are into research, you will see a number of kits that you will have bought in your course of conducting researches. It will be written there for experimental use alone. That means research generated of those type of kits cannot be used for diagnosis. Okay? Before a kit or a protocol can be applied for diagnosis, it must have been validated for diagnostic purposes. So we determine efficiency by determining predictive value, having compared a new technology with an established one, so that we don't miss road, we don't mislead physicians. Okay? So we look at sustainability. Film reading serves as a linking in the diagnostic journey, empowering healthcare providers to make informed clinical decisions. Based on our film reading report, clinicians can take decisions. Next slide. Yes. Film reading benefits continues. You have there, it improves our ability to comprehend lab technique as well in research. When we look at film, we are able to comprehend our lab technique, and it will enhance our proficiency in the performance of our procedure, help us to identify potential error or areas where we need to improve, and also it's useful in standardizing protocols across laboratories. For instance, there's what is called external proficiency testing. External proficiency testing, or what some people, if we have, some people, if you have external proficiency testing provider, or some people call it just PT, proficiency testing. In Nigeria, we have proficiency testing provider established by Medical Lab Science Council of Nigeria. They will just make 5 film of a known resource. They will have applied the right technology, the most efficient technology available. They will not send this 5 film to FMC, Yanagwa, FMC, everywhere, participate in that proficiency testing. Send in your report. They will compare report across board and provide insight onto, so that those performing those tests at all levels, primary, secondary, and tertiary care level, will be able to identify gaps in their procedure, so that our procedure can be improved upon. So these are the things we get from film reading. Next slide. Well, it also helps us in driving research innovation. Film reading will catalyze research innovation by serving as a resource of data for scientific inquiry. Before we even go beyond this level, when we talk about application of AI, artificial intelligence, you know, the only beauty that AI brings into the practice of film reading or morphology of blood cells, for instance, is that it has, or it harnesses the library of all manner of films, if it has been provided with such data. Unlike you and I, we have a number of we have a procedure by which we identify cell and all that. But if a machine that is relying on what is called machine learning, that is what AI does, is given a lot of data beyond what most human beings can comprehend. And an algorithm is now designed for that machine. Say, use all these features, numerous, to identify which one is a pseudo-thrombocytopenia, which one is a thrombocytopenia. So, it is through the knowledge of film reading that we are able to gather the data ab initio that we want to feed into the AI. So we are able to move beyond where we were last month, as of today, based on information that we have given to AI. So if you say AI is enhancing our capacity in delivering our services in our research, it depends on how much information we have given to AI. We know there's a common AI that we use free of charge. That one we declare its own inefficiency, say beyond February 2022, I don't know anything. You know that AI? Say, beyond February 2022, whatever I'm saying is not correct. Because his own brain tabulated February 2022. So, things like that. Yes. Film reading skill, how do we develop it? We have agreed ab initio, and the Vice Chancellor already mentioned it. The practice of medical lab science, for instance, or biomedical sciences generally, it is such a practice that once you enter into it, you have entered into a lifelong learning process. Even after becoming a professor, you still continue to learn. You continue to learn. Because whatever you have learned before, new information will just appear. You have to unlearn and relearn to become a learned person consistently. When we were in School of Medical Lab, University College Hospital, Ibadan, I have my classmate here, Mrs. Zakaria. We were together in the same class. Yes, you are welcome. That's the Director of Medical Lab Services from Lautech Teaching Hospital, Ogbomoso. When we were there, the procedure of ELISA that was correct and was unique for scanning blood donors, then third generation ELISA kit, second generation ELISA kit, that was correct then. If you use second generation or third generation ELISA kit now to screen donors for HIV, you are on your own. That is no longer efficient. In the minimum, you must now use fourth generation ELISA kit. That is in the minimum. If you can afford it, beyond that, you should begin to use chemiluminescence. And if you can afford it, come and use nucleic acid amplification technique. So we are talking about how film reading skill will help us. Why do we need to learn the skill? None of us should assume that I have known enough. Because what you knew yesterday may no longer be absolutely correct today. So that is why we need to identify key steps, analyze techniques, consider potential application. That is active viewing practices. Then we now utilize discussion and reflection exercises and integrate film reading into laboratory training program as trainers. That is for us, as teachers, as lecturers. We must not mount or continue to run a program where we don't continually review our curriculum using this step, even for our students. Yes, next slide. We are talking about film reading, and I have given few examples, all about human being. But the practice of biomedical science transcends human blood or stool or tissue assessment. We also have responsibility to know about other animals. Deliberately I said other animals, meaning that we ourselves, we are animals by sign. We are not by behavior. You know, we are animals. But when we talk about comparative hematology, we are talking about comparing cell morphology, function, and characteristics and features across species of animals. What you will see in human blood cells that say, this is an aberration. For instance, you see nucleated RBC in the cell of human being, peripheral blood film. That's an aberration. It may be an indication that that patient is having hemolytic anemia that is severe. That may be the reason, among other possible causes. Now, if you are looking at the blood film of a fish, the normal thing is to see nucleated RBC. Normal thing, the red cells are nucleated. So, you need to have this knowledge of comparative hematology if you are going to trend in film reading as a practitioner in this field. Next slide. And beyond that, look at one earth concept, one earth approach to disease. You know, what do we mean by one earth approach? Many of the emerging and emerging infectious diseases, they get into human through what? Through animals or through the environment. So looking comprehensively at what is happening to animal, what is happening in the environment, to be able to predict and treat or prevent ailment in human being. That is one earth. One earth. We are all into it together. Veterinary medicine is a practice that is relevant to human medicine. That is one earth approach. Yes. Okay, this is a comparison, for instance. Comparative hematology. Those cells there, they are from fish, and those red cells, they are nucleated. And those ones there, they are for human being. So we apply this knowledge of comparative hematology to understand human health, to advance our practice of veterinary medicine, and it's also applicable in evolutionary biology and environmental monitoring. Next slide. AI, I've mentioned a lot about this. Yes, AI involves development of computer algorithm that is capable of performing tasks that typically require human intelligence. But if you are using machine to do what human supposed to do intelligently, you have to provide that machine with a lot of information such that you're able to perform very well. But even with that, human being must be there to supervise. So we have machine learning algorithm which will help the interpretation of blood films. I've explained that. AI-based technology support system for the interpretation of complex lab results and formulation of personalized treatment plans for ailment. You see, that's what is called conferencing in film reading. The microscope that we see, where we have two viewers, one on the other side, looking at the same thing under focus, or three viewers, or five viewers, we call it multi-viewer microscope, is to ensure or enhance efficiency in diagnosis and also provide platform for training. Now, somebody will look at some lymphocytes, and with spine, you have lymphocyte that is having lateral spine. Can you imagine that? Lymphocyte having lateral spine. That is what is called atypical lymphocyte. And these lymphocytes that are having lateral spine, they are also very small. Small. You know, we have small lymphocytes and large lymphocytes. Between the two, the most mature one are small lymphocytes. But when lymphocytes are extremely small, we call them virocytes. Virocytes. It has diagnostic implication. So if 5 persons are looking at that film, for instance, now, if 2 persons are thinking they are too small and all that, 3 persons will bring their opinion, they will now use their scientific knowledge, discuss, and arrive at a consensus that will be used in issuing the 5, unlike what we have among judges. You know, when judges are sitting on a case, their lordships, when they sit on a case, 3 of them, 1 person can have another view and give his own minority report, opinion. He said, the majority of, they said this election is correct and all that, but only 1 person said this. In the case of American Science for Diagnosis, you have to agree. And that agreement is not going to be by democracy. You know, in democracy, we vote. In science, for diagnosis, we don't vote. We have 5 people now looking at a microscope, for instance. 5. One person is saying, I'm seeing phyrocyte here. 4 persons are saying no. This one person, oh yeah, we all defend it before us. You will now explain why this cell look like a phyrocyte. They will now remember, so they are correct. You see not one winning for now. So this is what we were not able to do because of COVID-19 in early 2020 to 2021. It was now the application of AI that helped us to do it. As we are seated here, if you need 5 microscopists to come and look at a slide, we can gather them. But if there is restriction of movement because of AI, and we need Professor Jeremiah to look at the film, is in Port Harcourt. Another person is in Calabar. We will stage that film here and use what we call digital morphology. All of us will look at it and we get a consensus. Meaning that if we apply digital morphology skill, we can actually get the best of the services to the remotest area in this country called Nigeria. As long as the slides are well made, you don't need to send the slide to me or to him or to her or to anybody. Focus the slide here. We apply digital morphology, we arrive at a result. It's not, we will not, so we should allow technology to impact positively into our practice. And that is what was used in UK, in US, in Canada in early 2020 during COVID-19. Limited movement, yes. Applied digital morphology, people were able to read slide and generate results of specialist taste and quality or status. So that is what we are talking about here. Beyond that now, AI is bringing something higher. Because with AI, many persons have contributed data. Many persons validated data contributed by them. Depending on how stringent the algorithm used by that AI is, it will be near perfection, near 100% efficiency as compared to one person show that we have in some of our lab. I must throw caution, the way AI itself will throw caution. And the way we have been taught, I said my teachers are here, when we say kit, we look at the definition of a kit. Kits are devices for professional use. Kits are devices for professional use. So when we say, yes, AI, it is not replacing biomedical scientists, so it is not replacing pathologists. It's not replacing laboratorians at all. It's helping us. Because eventually, whatever result that is now generated, having applied your AI algorithm, your result will be signed by who? By AI or by you? By you now. So it becomes a subject of litigation. Who will be held responsible? AI will not be held responsible. It's you. And that is why because you take responsibility, you must really be responsible from the beginning. There are things that machine will not see that you will see. I'll give you another example. Still about film reading. I think I've discussed this somewhere. They thought is a lad. Mr. Carrier will remember. We have what is called pseudo-thrombocytopenia. Our machine generated the platelet count that was very low by automation. And when you are on call in our lab, when they request for FBC under emergency, you release some results. You say, other result coming. Including platelet result was released during call. During working hour, we look at the film. Low platelet count, below 90,000. In fact, that one was below 50,000. That is thrombocytopenia. Meaning that result is telling the clinician, fire on the mountain. If you don't want that patient to bleed into the brain, to the body orifices, and any other thing, that patient is going to need what is called platelet concentrates. Okay? So, we now look at the film. We now saw what is called platelet satellitism and platelet clumping. Meaning that machine was only able to count free moving platelets, not platelets that have been attached to one another. And unfortunately, more than 70% of platelets in this patient has been attached to one another. It happens in patients that are sick. It also happens in people who are not sick at all. There is a type of antigen, we call it crypt antigen. Some individuals, they have that antigen on their platelets. Everybody have the corresponding antibody, but only people have this antigen. GP2B3A is the antibody. So this crypt antigen, by the name crypt, hidden, inactive antigen. What activates that antigen is, unfortunately, the most commonly used anticoagulant in the lab. What is that anticoagulant? EDTA. So once the sample is collected into EDTA bottle, the crypt antigen becomes active. And with the presence of the antibody, it will agglutinate, forming platelet aggregate or platelet satellitism, leaving only few platelets in the circulation that can be measured by automation. So patient was reported to have low platelet count. But by the Halley-Murray assessment, the film has revealed what is happening. And another bottle has been sent to the clinic or to the ward. Because in that case, there's no way if you collect sample into EDTA board 200 times, you will be getting wrong low platelet count by automation. So in that situation, this is an exception where you now say, okay, use trisodium citrate bottle. You know both EDTA and trisodium, they both chelate calcium. So you send trisodium citrate, bring that sample, we now run it, it will give you the real platelet count of that patient. AI will do that for you. AI will help you to do that. It's your skill that the Faculty of Medical Lab Science had provided platform for us to earn our skill in film reading. Not only thin film, thick film, and many other gram staining and all the other films. But don't be surprised that I am skilled because I'm a professor of hematology. So if I've not given enough example, but my skill in film reading, I give glory to God. I'm still sharpening it, but it's not below average. Yes, because in our days, as undergrad students, we were even taking calls. See, some of the battle some of us have in this profession, for instance, is due to our inability to truly provide the needed skill and knowledge that will help humanity, that will help patients. We need to improve on that. Once we improve on that, I believe, notwithstanding the inter-professional rivalry, people will still know our relevance. Our relevance. Yes, next slide. Next slide. Yes, I've discussed this. Nothing comparable to morphological assessment. This is general background in a blood film. This was not drawn from a textbook. This is a micrograph from that film. This is because I now, while preparing this slide, try to do what you call to make it so that's why you see this way. Next slide. Well, if you use AI, there's a machine now, they call it digital morphology. It is AI enhanced. I saw it somewhere here in Bayelsa State, maybe some 2 weeks ago. I asked for the price. They said it's 37 million naira. And they were promoting it only for malaria microscopy. I said, you don't know the full potential of this machine. And I tried to explain to them what the machine is supposed to be able to do. They now agree. But even when you use that type of machine or any other technology, or you use AI, look at these dictums of ethics. Professional use, I've explained that. Vicarious responsibility, I've also explained that. You are the one who will be responsible. You are the one who will be held responsible if there is any issue about the research. Confidentiality. Now, we have said you can share data about lab, about patient. How do you ensure confidentiality? You are the one that the patient has come to. It is in your lab that we are looking at this film. You must not reveal the identity of the patient or the co-partaker in the film assessment. They must not know, or else you are breaching confidentiality. You can see the technicality in this matter. And you look at research endeavor, which is continuous. And then finally, you must only use validated technologies. I think we have agreed on that. We have agreed on that. Next slide. Embracing technological advancements, this is a form of recommendation. In the digital age, the landscape of film reading is undergoing a paradigm shift with the advent of AI and machine learning algorithms. These technologies augment our interpretive prowess, expediting image analysis and offering predictive analytics to guide clinical decision making. As custodians of biomedical science that we are, it is incumbent upon us to embrace these innovations and harness their potential to propel our research endeavor to new heights. Next slide. Conclusion. We are concluding by saying that emerging technologies in biomedical science are revolutionizing diagnostic and therapeutic approaches, leading to improved patient outcome. Front-of-care testing and AI offer innovative solutions for disease diagnosis and management. Continued research and development in emerging technologies will further enhance our capabilities and expand their applications. Yes, collaboration therefore between all of us as scientists, clinicians, researchers, and technology developers, we call them application specialists. We need to collaborate to harness the full potential of these advancements in our time. Optimized and dynamic but responsive training curriculum is also key for quality education delivery in Nigeria and beyond. Yes? I thank you all for your attention.
The way you guys clapped is like this wasn't for the keynote speaker. Please, a round of applause. Which kind bacteria we go look where and go attack can be breast? In the case, I don't understand. A very precious part of the body. Can you imagine? Please, you guys should know what to do to that bacteria. Men don't want story. Okay, thank you for that enlightenment. We appreciate your lectures. Can imagine where a mathematician is enjoying a lecture in medical lab. The only problem I have with this particular faculty is the pronouncement of all those histo this, histo that, cyto this. I want to bite my tongue while trying to pronounce. In fact, one reason why I ran away from anything medical, medicine, my parents were on me, do medicine and surgery. I was running without looking back. Botanical names, those things dealt with me. To cram those things on this my small head, no, I ran away. I decided to go to the zone where I found comfort to go and solve maths for a living. You know, so I solve mathematics for a living. Okay, at this point in time, thank you once again. Let's not waste our time. I'm going to invite the second, the second speaker or the second presenter. There's a little, we altered it a bit because one of us has other engagements, so he wants to take his first. So I'm inviting to this rostrum Dr. Benjamin Eledo to come and give his presentation on patient-centered care and hematology, film reading, improving clinical outcomes, and patient experience. Doctor, I am the timekeeper. You have 15 minutes. Thank you, sir.
Thank you very much. Permit me to rest on the already established protocols. My name is Eledo Benjamin. I'm going to do justice to the topic, patient-centered care and hematology film reading, improving clinical outcomes and patient experience. When I got this topic, something was going on in my mind. I asked myself, Dr. Ben, all this time you went to school, the mathematicians were telling you to find X, find Y, find all this. The chemists and the physicists were telling you Newton's law of motion and all the rest. So all the years I spent in school is for the patient. And I tell all of you today, our students, all your endeavor trying to become medical lab scientists is for this singular patient. And this topic is centered on how to take care of this patient so that the patient will be satisfied. So in the course of preparing this topic, I first of all asked myself, who is a patient? And from the definitions I got, I was more impressed with the one that says that a patient is a person whom a hospital accepts responsibility for treatment or care. The question is this: how do you treat your patients? Some of us have formed the habit of treating patients wrongly. Let me start from the pre-analytical stage of our laboratory audit, where you collect sample from patients. I have seen situations where some of our colleagues will be shouting at patients, "My friend, stay well, I don't have time for you." Some of them will say, "Please do quick, I have other things to do." I want to tell you today that if you work in the hospital setting, the patient is your king, and you should know how to treat this king. Let me tell you a story. A colleague was in the lab, in the blood bank, and a patient relative came to collect blood for transfusion. And you know that blood is an emergency. And this colleague has worked from morning till evening, and she bought banana to refresh herself. As the patient relative came, she just said, "Please, let me eat my banana. I've been working since morning." And in the process of allowing her to eat banana, the patient relative ran away to sort out other things. On coming back to collect the blood, the patient has died. Did she treat the patient very well? The answer is no. So today we are going to look at patient-centered care. Let's look at the concept of patient-centered care. From my definition, I see patient-centered care as an individual's specific health needs and desired health outcomes when it becomes the driving force of whatever you are doing in the lab. Whatever you are doing in the lab should be centered on the patient. And we health care providers should treat patients not from clinical perspective, but also from emotional, mental, social, and financial perspectives. Some of us have duped patients that came to access our services. You will like doing PP. Some of us as PP specialists, you want to put little in your pocket every time. You are not treating this patient well. And there are some benefits of patient-centered care, and one of them, it improves satisfaction among patients, and their families. It enhances the reputation of their organization. Above all, also, it improves resource allocation. It reduces expenses and increases your financial margins throughout the care. Now, let's look at a blood film. What is a blood film? Let's look at a blood film, because this topic is centered on how do you use a blood film to satisfy your patient. A blood film looks at your three blood types. We have the erythrocytes, we have the leukocytes, and the platelets. Your blood film looks at them to identify any abnormalities. These abnormalities can be in shape, it can be in size, it can be in color, or in other inclusions. As my professor has said, you can be looking at a blood film, you see other inclusions like malaria parasites, you can see Wuchereria bankruptcy, as he has already elucidated, and this blood film gives you a visual clue regarding the functional state of your bone marrow. It also helps to identify systemic diseases, and this report should comment on the appearance of each of the cell types. What am I saying? As medical lab scientists, when you look at the blood film, you should be able to comment on the appearance of the red blood cells, on the appearance of the white blood cells, and the platelets. And as you are doing this, you are helping the patient to be given the right diagnosis and care. Now, for the blood film to give us good results, you should understand some of the criteria for a good film. As medical lab scientists, during training days, we are told that your blood film should have a head and a tail. It should not be too thick, it should not be too slim, it should not be jagged. So if you look at the slide, you should understand the criteria for a good blood film. I'm not going to bore you with that, but let's look at the principle. As I said earlier, your blood film enables you to evaluate the white blood cells, the red blood cells, and the platelets. It also allows you to perform differential count and also estimate the white blood cells as the case may be. Now, the three cell lines we are interested are the erythrocytes. We all know that normal erythrocytes is biconcave. They are all biconcave in shape, and they are pink in color. If you are reading your film and you identify any abnormality in this color, it is an indication of a systemic disease. Now, if the central pallor of your red blood cells is higher than the hemoglobinized area, is an indication that the patient is hypochromic. All these morphological abnormalities are essential for patient care when it comes to your erythrocytes. For your leukocytes, the number and morphology of each type of the leukocytes is assessed. For the leukocytes or white blood cells, you have the neutrophils, you have the lymphocytes, you have the monocytes, you have the basophil, eosinophil, and any derangement in the number is an indication of a disease condition. For instance, if you have a situation we call neutrophilia, which is an abnormal increase in the number of circulating neutrophils in the body, it is an indication that there is an invading microorganism of a bacteria or a bacterial agent that is in the system. Because the function of neutrophils is to engulf these bacterial agents by forming what we call neutrophil extracellular traps, net. That is the function of your neutrophils. So anytime you are looking at a blood film and you are seeing an increase in your neutrophil count, is an indication there is an offending or an invading microorganism in circulation. If you are seeing an increase in lymphocytes, what we call lymphocytosis, which can be relative or absolute. It is relative when your lymphocyte count is increased, whereas the total white blood cell count is normal. It is called relative lymphocytosis. But if there is an increase in your lymphocyte count with a corresponding increase in your total white blood cell count, it is called absolute lymphocytosis. Medical lab scientists should take note of this. When the lymphocytosis is absolute, it may be an indication of a cancer in the system. But most times when there is lymphocytosis, it's an indication, first indication of a viral infection. And from film reading, you can give doctors this clue and the patient will be treated very well. Now let's look at the thrombocytes, what we call the platelets. The thrombocytes may be increased or reduced. When there is an increase in thrombocytes, it is called thrombocytosis. When they are reduced, it is called thrombocytopenia. And all of these have different disease conditions. Because when we move to our next presentation, you will understand what all these things, the pathologies behind some of this increase or reduction. And the emerging trend in film reading these days is that you don't only tell a doctor that there is an increase or a reduction in any of the cell lines. You must understand the underlying pathologies and suggest to the doctor that this increase is suggestive of this. So when we move to the next presentation, we are going to take you on a voyage on what all these increases or reductions will point to. And when you give the doctor these pointers, the patient will be happy by the end of the day. Now let's look at the film report. The film report usually comments on the appearance of these cells, and there are many indications for you to do this film. And some of the indications are common clinical situations of the peripheral blood analysis, which include unexplained cytopenia. Unexplained cytopenia is when there is reduction in the cell lines. And when there is total reduction in all the cell lines, it is called pancytopenia. Take note of that, pancytopenia, when there is reduction in all the cell lines. Also, when there is unexplained leukocytosis, it is an indication for a film reading. When there is unexplained jaundice or hemolysis or features of congenital hemolytic anemias, it is an indication for you to request for a film report. Most of our young or neonates today, they present with jaundice. And when there is a request for film report and the report is being taken good care of, the patient will get the maximum care from us. Also, when there is other issues like splenomegaly, in those days when we are in the village, when the child presents with splenomegaly, which is an abnormal enlargement of the spleen, we usually take them to the native doctors to go and press their tummy. As medical lab scientists, I want to tell you that those practices are no more fashionable these days. When a child is having splenomegaly, it means that the spleen is working so hard to remove what we call effete red blood cells. These are red blood cells that have lost their functional capacity. It is the duty of the spleen to mop up all these red blood cells and remove them from circulation. So when the spleen is working so hard to perform this function, there is that tendency that the spleen will do what? Enlarge. And that is what these little children present. After this presentation, when you see some people using native concoctions to praise the stomach of children, shout at them and tell them it is no more what? Fashionable. That is what you call splenomegaly. And it's an indication for you to ask the patient to go for a film reading. And by the end of the report, you will see evidence of hemolysis. If there is evidence of hemolysis, you now know that the spleen is trying to mop up what you call effete red blood cells from circulation. In conclusion, the healthcare system has a mission and value, and it is all centered on quality improvements in patient care. This care should focus on the physical comfort of the patient who visits the laboratory for hematological investigations. Therefore, patients should have trusted personal relationship with the medical laboratory scientist who uses peripheral blood films in screening, diagnosis, and monitoring of diseases. Thank you very much for your time. Next slide, the next presentation. Thank you very much. The learning objectives, at the end of this presentation, all participants should be able to understand the various indications for peripheral blood films. We should go into the rudiments of film reading. We should also know the various abnormalities in erythrocytes, leukocytes, and thrombocytes. And finally, we should know the associated pathologies in these abnormalities. Introduction, please. Now, it is a well-known fact that 70% of the clinical decisions made in every hospital are dependent on laboratory investigations. There is no argument on this. Peripheral blood film is a basic and highly informative hematological tool in screening, diagnosis, and monitoring of disease progression and therapeutic response. The import of this statement is that peripheral blood film is an important tool in patient management. Next slide, please. I've already told you the indications for peripheral blood film. I've also told you what film does. Now let's look at abnormalities of erythrocytes. The abnormalities of erythrocytes can be in size, it can be in number, it can be in color, it can be in shape, it can be in arrangement or inclusion bodies. Now, one of the basic abnormalities in the red blood cells is what we call macrocytosis. Macrocytosis means that the red blood cells are larger than normal. You can see a micrograph there. Please, media, please get the micrograph showing macrocytosis. You can see the normal red blood cells. You can see the macrocytic red blood cells. Now, one of the causes of macrocytosis is what we call vitamin B12 deficiency. Most times, when a patient comes to the lab to assess our services, we only say macrocytosis 1 plus or macrocytosis 2 plus, or as the case may be. But we don't go to the end of suggesting what could be responsible for the macrocytosis. So take us back to the former slide. Let us know the associated pathologies, because the emerging trend in film reading today is that you don't only report films or report abnormalities in the films, you should also suggest what could be responsible for these abnormalities so that the doctor can treat the patient and the results will be very wonderful. One of the associated pathologies that lead to this macrocytosis is pregnancy. A pregnant woman will have what we call a deficiency of what? Vitamin B12. And that is why most times during pregnancy, most pregnant women are given supplements. True of us? It's just to enhance the level of their vitamin B12. No matter how rich you are as a man, your wife must go through what you call physiological anemia of what? Pregnancy. And this physiological anemia is caused by the increase in the red blood cell mass caused by the presence of what we call HCG. HCG is what we call human chorionic gonadotrophin, and that is what we check to confirm that a woman is pregnant. So this HCG has a way of causing some funny episodes in the body of a woman, or what we call dilutional anemia. And what we call the plasma volume will be higher than the red blood cell mass, causing what? Anemia. And every woman, you must look pale during pregnancy. Now, the next associated pathology is hypothyroidism, or what another one is aplastic or pernicious anemia. Pernicious anemia is a kind of macrocytic anemia or megaloblastic anemia where there is deficiency of intrinsic factor. Students, take note of this, it's a vital question. Pernicious anemia is different from megaloblastic anemia because megaloblastic anemia is the deficiency of vitamin B12. But in pernicious anemia, there is deficiency of B12 caused by the low level of intrinsic factor. And intrinsic factor is the protein that transports vitamin B12 to areas that are needed in the body. So there you can have dietary supply of vitamin B12, but there is no intrinsic factor to transport them to where they are needed. That is what leads to what? Pernicious anemia. Next is macrocytosis caused by ovalocytes. I think we have played that side. Let's move. The next abnormality we have here is microcytosis. Microcytosis can be presented in cases of iron deficiency. Iron deficiency leads to what? Microcytosis. Now, the associated pathologies, you can have rheumatoid arthritis can lead to microcytosis. Sickle cell anemia can lead to microcytosis. Thalassemia can also lead to microcytosis. Next is iron deficiency, which I have mentioned. And the next slide will give you a pictograph of what a microcyte looks like. If you look at this picture, you can see normal red blood cells, which are biconcave, but you have seen the cells that are lower, they have the little size that are smaller than the normal red blood cells. That is what we call microcytosis. For some of us that are using automated system, when there is microcytosis, if you look at the red cell indices, the mean cell hemoglobin will be lesser than normal. And when you see this type of thing, be bold enough to tell the doctor that this microcytosis is suggestive of iron what? Deficiency. So that when the doctor is treating the patient, iron supplements can do the magic. In the next few days, the patient is out of the hospital. Anisocytosis is the next, which is variation in size. In this case, there is a mixture of microcytes and also macrocytes. And the underlying pathologies include megaloblastic anemia, hemolytic anemia, and sepsis. What is sepsis? When there is a bacterial attack in the system or systemic invasion of bacterial cells leading to pyresia, when these bacterial cells release their toxins. The next slide picture will give you what anisocytosis. You can see different sizes, both big and what? Small, presence of macrocytes and microcytes. The next is dimorphic blood picture. And this describes a heterogeneity in the size of the red blood cells, usually two distinctive size. We call them dimorphic picture. And the associated pathologies include partially treated anemia. When somebody that's anemic was partially treated, you have a dimorphic blood picture. The next is during after transfusion. You know, most times it's very important to indicate when a patient has undergone transfusion, so that when you see this kind of picture, you can suggest it's as a result of what? Previous what? Transfusion. Now the next is increased space between red blood cells. This one indicates lower volume of red blood cells. I don't want to bore you too much because the slides are plenty. Now, hypochromia. Hypochromia is an indication that shows that the central pallor is higher than the hemoglobinized area. And if you look at the micrograph, you will see that hypochromic cells is an indication of severe anemia. When you look at the central pallor, that's the place that is not stained. If it's higher than the ring of hemoglobin, you say the cells are hypochromic. And the associated pathologies, as I mentioned earlier, can be thalassemia, can be iron deficiency. Lead poisoning is another indication that causes what? Hypochromia. Now, polychromasia is what we call heterogeneous staining of red blood cells due to RNA retention in larger immature cells. It indicates marrow stress or hemolysis. And some of the associated pathologies include hemolysis and post-hemorrhage. Somebody that has passed through bleeding, you can have what we call polychromasia. Now, let's look at the shape of the red blood cells. When there is a difference in the shape of red blood cells, the general name for it is what we call poikilocytosis. Poikilocytosis is an abnormality in the shape of the red blood cells. And there are so many poikilocytes we can mention. There are many. We have the spherocytes, we have the elliptocytes, we have the stomatocytes, we have the codocytes, or what we call the target cells, we have the schizocytes, we have the dacryocytes, or what we call the teardrop cells, we have what we call the keratocytes, or the blister cells, we have the mastocytes, or what we call the bite cells. We have the acanthocytes. I would love the media team to project the acanthocytes so that you will understand okay, this is a general picture for all the cells I'm mentioning. You can see them here, the stomatocytes, the schizocytes. You can look at the spherocytes, they are all projected there. And when you get the slides, you will understand the underlying pathologies behind some of these cells. Now let's look at abnormalities in leukocytes. We have 5 cell lines in the leukocyte series, as I mentioned earlier. You have the neutrophils, you have the lymphocytes, monocytes, eosinophils, and basophils. Now, when there is decreased number of lymphocytes, it can be as a result of idiopathic neutropenia, hypersplenism, or fatty syndromes. I would like to explain hypersplenism, as I was trying to use the demonstration of a young child that is having splenomegaly. Hypersplenism is a situation where the spleen goes gaga and starts mopping up all the cells in the body. The spleen goes gaga and start mopping up all the cells, the neutrophils, the lymphocytes, and this will present with neutropenia in the system. Now, left shift of neutrophils, this shows immaturity. Hypersegmentation shows when the neutrophils have many granules, or what I call they are hyper-segmented. The lobes are more than 5 and above. Thank you very much. That is called hyper-segmentation. Some people can present it as over-maturity, as the case may be. It can be seen in severe infection, in inflammatory disorders, in chemical poisoning, or alcohol abuse. Anybody that abuses alcohol all the time, you will have hyper-segmented neutrophils. Now, let's go to the lymphocytes. When there is lymphopenia, it usually occurs commonly in viral infections. I've told you earlier, the first cell lines that are released to attack viral agents is the lymphocytes. And as they go in, they sacrifice themselves, it may lead to lymphopenia, as the case may be. Lymphocytopenia is reduction in the number of circulating lymphocytes in the body. HIV can also cause lymphocytopenia. And you know this, that's why you do CD4 cells for HIV patients to know the level of destruction of the CD4 cells. And when it is less than 300, the person has to start antiretroviral therapy. Now, I've mentioned relative lymphocytosis and absolute lymphocytosis. The next cell line is the eosinophils. Eosinophils are increased when a patient is in a hypersensitive state or when there is an allergy in the system. Another indication for eosinophilia is parasitic infection. Most neonates or most pediatric patients, if you do an eosinophil count and there is marked eosinophilia, it is an indication that the little child is harboring a parasite in the body. And if you give this indication to doctors, it helps the patient very well. Basophils are involved, are very rare cells in the body. The reference range is 0 to 1, so I don't want to disturb you about basophils, but they may be increased or reduced in a situation what we call basophilia or basopenia. The associated pathologies include hypersensitivity states, chronic sinusitis, and lymphomas. Then the monocytes, we have monocytosis or monocytopenia. It can be as a result of chronic bacterial infection, rheumatoid disease, and inflammation. Finally, thrombocytes. Thrombocytopenia, which is a reduction in platelet count, can result from reduced production by the bone marrow, increased splenic sequestration, as in hypersplenism. Then we have thrombocytosis increase in number of platelets, can result from infection, major surgeries, hemorrhage, and acute hemolysis. In conclusion, in hematology practice, the examination of blood smears and their morphology remain an indispensable tool and a frontline diagnostic jigsaw in unraveling mysteries behind cryptic symptoms. Therefore, we should do well to give good film reports to make sure that the patients whom we are all learning to take care of get the best care from us. Thank you very much for your time.
A round of applause, please. Thank you, thank you, thank you. I didn't inform you people that in 2014, when I came to this town, it was in his place that I found refuge. He's my big brother also. So, Dr. Ben, we appreciate your lectures. Thank you. And to my dear students, wonderful students, those who think that despite the fact that you are supposed to be in the house enjoying your holidays, you decided to be here today to learn. Let me tell you one thing. I once told a student during an exam who was trying to copy. I said, what are you doing? Why didn't you study at all? He said, sir, in your own days, are you saying you people don't used to copy? That was what the student asked me. And I said, if I copied, would I be teaching you? The unfortunate thing with you is, if you want to be a lab scientist and you want to copy your life through the process, you will be one of those roadside lab scientists giving people wrong diagnosis. And your pay is in hellfire. Because you took your time, the time you would have used to study, you took it to go and do Yahoo Yahoo and do all those stuff. I refuse to study. Therefore, from all he has said here, you can agree with me that this is a practical course. This is a course that when you say, I am a graduate of medical lab science, you must show working. You must bend down, you must understand the process. Sometimes you don't even need to, some people will do some things that you have to go and attach yourself to some of these people so that you can learn without being paid. Some people do it. At this point in time, I'm going to invite the second presenter in the person of Dr. Emmanuel Onoha. Please, can you come forward, sir? Please, sir, you have 15 minutes on the dot.
Thank you very much. Standing on the existing protocol, I'm talking on the hematopoietic stem cells, mechanism, and proliferation. Please, can we have the slide? It's okay. I have the presentation outline. Okay. Yeah, this is the learning objective. Please, next slide, since I have 15 minutes. This is my presentation outline. The next slide, please. Let's talk about definition of hematopoietic stem cells. Since we are talking about hematopoietic stem cell, mechanism, and proliferation. I say hematopoietic stem cell are adult stem cells. Underline that word in very bold. What do? They have the capacity for what? For a long-term self-renewal. Not only that, and can also differentiate into a various matured blood cells. Now let's see the picture. Can you go to the next slide, please? This is a structure of hematopoietic stem cell. Of all we have been saying, there's no way we can talk about blood film reading without talking about the genesis. What we are talking about now is the genesis. Where did it originate? The beginning. The Bible says, in the beginning there was what? Heaven and earth. So in the beginning of blood film, there was what? Hematopoietic what? Stem cell. And we say, remember the definition that the hematopoietic stem cell is what? Is an adult stem cell that do what? Have the capacity to differentiate. You can see this myeloid cell and this lymphoid cell. The hematopoietic stem cell differentiate into myeloid stem cell and lymphoid stem cell. And we say also can differentiate into mature blood cells. Basophil and Sanofi, as we have the last presenter, neutrophil, monocyte, platelet, erythrocyte, lymphocyte are the matured what? Blood cells. Can we go to the next slide, please? Next slide. So we say hematopoietic stem cell, the mechanism and the proliferation. And of course, when we are talking about all peripheral blood film cells differentiate from the hematopoietic stem pool in the bone marrow, of course, what we have said already. And the production of this mature cell, it have a multi-step process. Next slide, please. Now look at the mechanism. We have two major mechanisms: self-renewal and replication, multi-lineage differentiation. Next slide, please. When we talk about self-renewal and replication, we are talking about a process in which a stem cell generates at least into one daughter cell that can retain stem cell characteristics during cell division, which we call mitosis. This process will enable the stem cell bank to exist throughout life cycle, and this is the basis for the maintenance of the lifelong regenerative potential. It then means that the number of hemostatic stem cells still remain unchanging regardless of how many times they divide, and this also enables them to generate progenitor cells to meet organisms' differential needs. Next slide. Now, when we talk about multi-lineage differentiation, is into three main types. We have long-term hematopoietic stem cell, we have short-term, and we have also multipotent progenitor cell. They varies in their differential potential. But when you talk about the long term, is the top of the hematopoietic cascade. They maintain the multi-lineage hematopoietic concentration for a long period. Notably, they are the only cell population with true hematopoietic characteristics. The short term happen only between 6 to 8 weeks. Next slide, please. Now, furthermore, with what we are saying, this is actually the major thing we want to present, that this multilinear differentiation will actually differentiate into two lineage, which is myeloid lineage and lymphoid what? Lineage. And in the peripheral effector of the cell, we're establishing that in the myeloid lineage, we are going to have in the myeloid lineage, we are going to have the T lymphocyte, look at what I'm saying. This is actually the lymphoid progenitor cell. This is the myeloid progenitor cell, and the differentiation, remember, is from the bone marrow. And the lymphoid progenitor cell, we're going to have all those B lymphocyte, T cell, B cell, and natural killer cell. Then the myeloid lineage, we are going to have that the end of it is going to be the platelet and the monocyte, erythrocyte, neutrophil, and so on. Can we go to the next slide, please? Now, what is the role of hematopoietic stem cell in blood film reading? We first of all talk about the relationship between the hematopoietic stem activity and blood cell and abnormalities. Now, the next slide. Let's look at this picture, like the last presenter and the keynote speaker said. You can see we are trying to take them one after the other. Remember the differentiation, myeloid and lymphoid. Now we want to take it in the line of electropoiesis, which is the red cell. You can see the electropoiesis starts with you can see the red shape, the morphology, the first morphology, and until you get to the electrocyte, the electroblasts have nucleus. As you go down, you are going to see what the matured red blood cell with that nucleus. And of course, when we are reading a film, this is one of the things we put under consideration. When you come to a peripheria, this is actually what you see. The reticulocyte, that's what you get, and then when you go to the intravascular form, which is in the red blood cell, look at what you are going to see, the erythrocyte. And for basophil, this is what we see, neutrophil, and all other ones. This is what we are going to see. But in a situation where you are doing a red blood cell, when you are doing a film reading, and it happened in the intravascular cell form, and you are seeing all those ones we are ought to see in the bone marrow, that will show you there is a problem in that system or in that patient. Can we go to the next slide, please? Now, look at the abnormalities. Look at the hematopoietic stem cell. When there is no insult, when there is no attack, you have the normal blood cells. But when there is an attack, you have like leukomogenic insult. What you are going to have like leukemogenic stem cells. What you are going to produce is what? Leukemic blasts. In the blood film, this is what you are going, kind of picture you are going to see. And of course, these pictures, when you go back to what we show, you see that some of this picture is some of the things you may see in the bone marrow instead of the peripheral blood film. The next slide, please. Now, in conclusion, we said that abnormalities in hematopoietic stem cell can have a profound effect in blood cell production and function, leading to various abnormalities formed on the blood film. Recognizing these abnormalities is essential for diagnosing and managing hematological disorder effectively. Understanding the role of hematopoietic stem cell is vital in interpreting blood films accurately. Recommendation. Blood film reading should be included in the school curriculum as a separate course with intensive practical. And I want to tell you that by the grace of God, in the CC Mass, we have included this as a part of the course. Next slide. This is 500 hematology and blood transfusion. And of course, you can see film reading and report, FUO MLS 567. So final year students, get ready to the course of film reading and reporting. The purpose is that we need to go back to the fundamental and get what we need. Next slide, please. Next slide. Thank you for listening.
Thank you, Doc. Thank you so much. A round of applause once again. This man does not belong to the African time people. Keep it up, sir. Your time is your time. Okay, so the next presenter is going to present on histology stroke cytology slide reading. Histology stroke cytology slide reading, decoding tissues stroke cells signatures. And this presentation will be done by Dr. Honorio Day Andrew Udi. Oh, my man.
Thank you. Okay, because of time, let me stand on the, I was given 20 minutes, sir. Okay, all right. Let me stand on the existing protocol, histology and cytology slide reading, decoding tissues and cell signature. Please, next slide. From my introduction, slide reading is actually an essential aspect of both histology and cytology. You know, it involves careful examination of prepared slides under microscope. You know, the whole process of slide reading all begins with slide preparation, that is tissue preparation. So, next slide. So, it involves careful examination. Careful examination, we were told earlier on that you must have a trained eyes. A trained eyes. When it comes to either through the wet mouth, tissue section, or normal blood smell. So slides are prepared with series of steps that involve normal fixation, that is immediately after harvesting your tissue, that is for histology, normal tissue processing, dehydration, and the rest of them staining. Next slide. So, reading histology and cytology slide, I told you that it begins with processes, with the use of microscope. And so you start with the times 10 magnification, that is low magnification. Within this low magnification, you just get a general overview, especially if you are using your normal H and E, okay, to get the general orientation or the general histoarchitecture of the cell or the cytoarchitecture of the cell, of the tissue. So you move from times 10 magnification to higher magnification. With the higher magnification, you'll be able to see the variation in cell size. So you can now compare the same stain cell and your stain cell. Meanwhile, as you are doing this, you must have, I did say this earlier on, you must have the basic knowledge of your histology or your cytology. So pathologists will tell you that it's even better you have a test with you, especially when you are looking at various microscopes. You are trying to differentiate between the abnormal from the normal. So with this, you can make your diagnosis and make your conclusion. Next slide. Then you must also put this into consideration, issue of artifacts. Sorry, I'm saying this assuming that we all have some little knowledge on histology or histological processes. So you must have in mind that artifact may be present, because artifact can lead one into erroneous conclusion when you are doing your slide reading or histological reading. So artifact as it is, they are structural features that are not part of the sample, but they appear on the slide due to error during preparation. These include like bubbles, especially when you are trying to get your ribbon on your water basin, the hot water basin, when you are trying to pick it. If you are not careful, sorry, mounting, when you are trying to mount your slides, your tissue, if you are not careful, you may end up having some bubbles or some debris, especially if the water is not clean, or in the process of picking it, if the ribbons are not well straightened, you may end up picking folded ribbon. So it is also important to be aware of some common artifacts that you must ensure to have accurate interpretation of results. Next slide. Now, slide reading also involves interpreting the structure and components that are present in the slide. And it required knowledge of normal appearance of the cell, which I mentioned earlier on, then the tissue, before you can talk about the abnormal, which is pathology. Next slide. Then quality control. There must be quality control and assurance. And the quality control has to do with regular checking and maintenance of your microscope, and not just the microscope alone. Those materials or your equipment you use in preparing your slide, there must be quality control. If not, the issue of artifact may come into place. So for proper documentation, you must have proper documentation and record keeping of results. Next slide. Then decoding tissue. This actually have to do with identifying and interpreting the different types of tissue that are found in living organism. And you must have the knowledge. Knowledge is very important in this field, especially when it comes to medicine, biology, and so on, for better understanding of how the body works. So there's need to have process of identifying tissue, which we are going to look at as we continue. Next slide. Cell signature. has to do with the unique characteristics of the cell that distinguish a particular cell from other cell. For example, like the cell signature is important, that is important because they provide valuable information about cell's identity. So identifying cell signature involve analyzing various aspects of the cell, such as the gene expression, morphology. For example, the previous lecture, we were told about splenomegaly. Now, when you are viewing a slide, let's use the spleen as an example. There are times you may see, the red pump and the white pump. The white pump ought to be very small within the tissue, because when we are looking at this size now, the size or the morphology of the cell, there are times when you view a slide, because of trying to interpret a slide. Normally, there's what we call the septal trabeculate, that is a connective tissue that contains blood vessel that make the red pump and the white pump to be in patches, then patches of lymphoid tissue, especially the white pump. But there are times you may see the way you may see a kind of enlarged form of it. Once there's a large form, it calls for critical, identification to know, maybe for further processes, to know what has actually gone wrong. It can be pathological. There are times even the septal trabeculum that act as a connective tissue that split them may even be absent, may not be seen. So without that will give you an impression that something have gone wrong. So this can be done through the techniques such as microscope, flow cytometry, and gene expression analysis. Next one. Okay, go to the next one, next slide. Good. Then recognizing cell structure. This is where the knowledge of normal come in, that is anatomy, cell anatomy. Knowing because we are talking about cytology now, knowing the cell membrane, how does the cell membrane look like? How does the cytoplasm of a cell, the nucleus, how do they look like? So you should be able to have good understanding of the cell anatomy, and that is why for medical laboratory science at 200 level they undergo anatomy, especially histology, and not just histology, even the gross anatomy, so that they know how these various structures look like, the normal. So that when you are now in 300 level, you'll be able to appreciate the normal from the abnormal pathology. Next slide. We have just mentioned, next one. Yes, cell types. Okay, like the red blood cell, how it look like, which we were told a few minutes ago, the white blood cell, the nerve cell, muscle cell. So you should be able to also understand the basic tissue. How did they look like? The basic tissue. Talk about the epithelial cell, the connective tissue, the muscle tissue. What are the various types of epithelial cell? How did they look like? In such a way that, take, for example, from the basic histology, if you see a particular tissue, for example, like from the kidney, to the urinary bladder, the ureter, if you see a ureter, you'll be able to see some histological characteristics, that this histological characteristic will make you to know that, yeah, this cell is different from this other one, especially the epithelial tissue. If you see the epithelial tissue of the ureter and the urinary bladder, which is the transitional epithelium, you see the cells that are in transit, moving from one particular epithelium, especially when there's urine in the urinary bladder, the cell is likely to change to a different cell. That's why we call it transitional epithelium. Or when you go to the kidney, you see the covulated tubule, you see the cuboidal cell. These are the basic histological knowledge you must know before you can interpret tissue. Next slide. Good, which I just mentioned. Next one, please. Next slide. Yes, cytology slide reading. Okay, the structure, function, abnormalities. It is important that diagnostic tools use immensity and research to detect and diagnose disease at the cellular level. Okay, next slide. Like the blood sample, urine, tissue. Tissue has to do with like taking biopsies, urine, taking urine sample, blood sample. Next one. Then interpretation of abnormal morphology. Like during cytological analysis, like what I've mentioned earlier on, you must put into cognition the cell size, the normal size of the cell, the shape of the cell, which is the morphology, the structure of the cell. They are being examined under the microscope. Then if there's any abnormalities, like the white pump I mentioned earlier on, if the white pump they are in patches, or if people go to the brain, seeing the glial cell, like the oligodendrocyte, the astrocyte, a situation whereby you are not seeing the oligodendrocyte in the brain and the astrocyte moving towards a particular area, you are not seeing kind of gliosis, that is multiple of the astrocyte. Without that, will tell you that there is already abnormality that may take you to maybe further analysis. So cancer cell may appear larger with irregular shape and size compared to normal cell. These are things that you must have in your tips before you can go into interpretation of cell, like the pap test, the taking biopsies, which I just mentioned. Next one, please. Next slide. Benefit and limitation of cytology. Cytology is also a minimally invasive procedure and does not require surgery. Cytology has some limitation. It may not always provide definitely diagnosis, but further testing may always be required. Additionally, small or rare abnormality may be missed during cytological analysis. That is why you don't just draw conclusion. So it is important to interpret cytology results in conjunction with some other clinical. Next slide, please. Common abnormalities and their significance, like cell changes in cancer, which I mentioned earlier on, having abnormal cell growth and division, changes in cell size, abnormal cell structure, loss of cell specialization, and so on. Next slide. Then inflammation and infection, like the brain I mentioned earlier on, when you are seeing oligodendrocyte, astrocyte, or other glial cell like microglia, seeing many division of gliosis, you should know that there is kind of inflammation or infection. So redness, like normally redness or wound or swelling, normally even as you are, once there is any swelling in your body on within your skin, you know that something have gone wrong. Fever is a common response to infection and inflammation as the body rises to fight off invading pathogens. Please, next slide. Then autoimmune disorder, like autoimmune disorder often involve chronic inflammation, which may cause range of symptoms and complications. Next slide. There are still some other abnormalities and their implications, like abnormal blood cell count. I don't want to dwell at all in this area because it will be overflowed today. Then pitfall and tips for accurate slide reading. One, inaccurate slide reading can lead to incorrect diagnosis and potentially harmful treatment, like what we were told earlier on about diagnosis of breast cancer. If not that there was further further work that was done on it, maybe it will have led to harmful or complete mastectomy of the breast. So it is important for healthcare professionals to be aware of potential pitfalls when examining slides, as well as tips for avoiding errors and maintaining accurate record. Then we may mention artifacts. Artifact is very important to watch out for. Then to avoid artifact, it is important to handle slides carefully and follow proper staining processes, because all these begin from the normal tissue processing. Once you miss it, for example, somebody that is in a hurry, if you are preparing tissue, you're supposed to dehydrate for 30 minutes, or you're supposed to move from 50% alcohol for dehydration, 50% alcohol to 70 before you get to 90 or 95 before absolute. Now you just move from 70% because we are in the hurry, you just move from 70% to absolute. What do you think will happen to the tissue? It will shrink, and this will give you wrong interpretation. Next slide. Then to avoid misidentification, it is also important to label slides accurately and consistently. This includes labeling slides with patience. I remember when I was supervising some students some years ago, about 3 or 4 years ago. Now, the students, they failed to label the slide properly. At the end of the day, everything were mixed up. Honestly, I was able to identify the slide by viewing the slide with the aid of microscope, but I find it difficult to know those in group 2, because group 1 is the control group, group 2, group 3, group 4. So what with the students, they have to start it, go back to begin the work from afresh. I mean from sessioning, because they have missed it up. So there is need for accurate or proper labeling of slide, because it is also helpful to label the slide with the type of staining used. So to avoid misinterpretation, it is important to carefully examine the entire slide with the aid of microscope. You take note of any abnormal structure or feature. It's also helpful to consult reference. That is why it's good, either you through your internet textbook, you get close to yourself, the normal tissue, then as you are viewing the ones you prepared, to check for any abnormality or any deviation from the normal. Next slide. Next slide, please. In conclusion, proper histology and cytology slide reading is crucial in accurately diagnosing disease and providing appropriate treatment for patients. It requires a combination of technical skill, knowledge of anatomy and pathology, and a keen eye for detail. The following are some key points to remember. 1. Accuracy is essential in slide reading, as misinterpretation can lead to misdiagnosis and inappropriate treatment. 2. A thorough understanding of anatomy and pathology is necessary to identify normal structure and abnormalities. 3. Attention to detail and careful observation of cell morphology are essential in identifying changes that may indicate disease. That is why it's good, if you are not a type that views slides regularly, it's good there is a second check before you draw your diagnosis. I remember during my MSc work, I was supervised by pathologists. Having interpreted the slide, it drew my attention to some little things that I felt this is normal, but they are not actually normal. Quality control, what I said earlier on, quality control is also very important. That is proper staining techniques and adherence to standard protocol. I said that before. They are very crucial in producing high quality slides for accurate interpretation. Ongoing education and training, we were told by one of the guest lecturers, there's need for continuous training, for continuous viewing of slides, continuous learning. Ongoing education, like what I said, is very important. So the future of slide reading is constantly evolving with advancement in technology. So digital pathology, where slides are scanned and viewed on a computer screen. Unlike those days that you have to interpret the slide with the microscope, but this day you can capture and interpret. You can even send it to anybody to interpret from anywhere. So overall, proper histology and cytology slide reading is a vital component of patient care and plays a crucial role in disease diagnosis and management. With continued education and advancement in technology, slide reading will continue to improve and provide better outcome for patients. Next slide. Reference, next slide. Thank you for listening.
A round of applause, please. Are we tired? Are we tired? Akwụkwọ na-atọ ụtọ, ọ na-arahụ na mmụta. You know that? Okay, you are not Igbo, so I don't know how they sing it in your own language. You can interpret in your own language. Okay, so it's been a wonderful exercise. Sorry, I missed this part of the lecture, but I'm sure, as usual, it's going to be enriching. Okay, so we have the last person for today before we take few questions. The last presenter is going to talk about insights into film-based microbiology diagnosis. And the person to present this is Dr. Faith Okelue, Department of Parasitology, FMC, Bayelsa State. Doc, are you around? Oh, okay, round of applause for Doc. You know, since men have been presenting, you guys have been looking so bored. We need to now listen to, okay. Oh, okay. So please, Dr. Precious Allison is the one presenting the same topic. All right.
All right. Since we came, we've been listening to men, and it looks like we are tired. Can we just stand for 1 minute? Just shake, 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 shake around. So our last presenter, when you people clap for him, you didn't clap very well. So we're going to do the clapping now. When I say Atama, you do 1. Atama, 2. Atama. Laparena, you now clap heavily. So let's clap for him. 1, 2, let's go. Atama. Atama. Laparena. 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 I guess you were awake now. Okay, so I'm really going to run. I'm not going to waste that time. Let's sit down. Okay. I am Dr. Precious Alisi, and I'm told to do justice to film-based veterinary diagnostics, film interpretation of animal sample. Now, next slide. Okay, now, the use of laboratory animals in medicine cannot be overemphasized. You cannot totally talk about medicine without talking about laboratory animals. And so they help us in drug development, they help us in procedures, medical procedures like preparation of our reagents, and we can use them to test new drug formulas and supplement formulas. Next slide. Okay, these are the objectives. Next slide. Okay, so what are these laboratory animals? These are vertebrate animals, whether traditional or agricultural animals, wildlife or aquatic species, produced for or used in research, testing, or teaching, whatever one. you can decide to set up an experiment in the lab which you're not going to use humans. You divide your animal into different segments and achieve the treatment that you want. You can decide to induce diabetes on a laboratory animal and research a particular agent, its ability to bring a hypoglycemic effect. You can even induce a high blood pressure in a laboratory animal. You can induce cancer in a laboratory animal. Whatever you want, you can induce in a laboratory animal in a controlled condition and try to test the effect of a particular agent. And so that's where laboratory animals play a lot of role. And so but there are basic concepts to use of laboratory animals. Next slide, please. And what are these basic concepts? Please, can you go to that slide there? Basic concept. There are guidelines to use of laboratory animals. You don't say they are animals, so you just handle them anyhow. There are rules and regulations. You can actually be sued if you do not handle laboratory animals well. And these guidelines or rules, they start from preventing their contacting diseases, that's disease prevention in laboratory animals, their management, their handling, their nutrition, their care. Just the way you treat a human being, that's how you treat laboratory animals. You don't treat them less because they are animals. Even when you are going to sacrifice them for the experiment you want to do, you don't make them go through pain. You have to anesthetize them before you do such, and that's the basic concept. Now, the history about the use of laboratory animals dated well back in the 320 BCs, and the first person was Aristotle that did experiment with laboratory animal. He kept dissecting animals and came up with the fact that, look, this differentiates a rat from a mice. This structure in the body differentiates a rat from a rabbit. That was the initial experiment we had with laboratory animals. And then over the years, we kept having experiments like that. And then the last that was recorded before the recording stopped was in 1920 when Best and Co. They isolated insulin. You know, formerly insulin that we use for treatment of insulin-dependent diabetes was actually produced from animals before the recombinant protein technique came up. And then that's what is being used. And after that, the counting stopped because so many people all over the globe were now beginning to use experimental animals or laboratory animals for their experiments. We go next slide. Okay, so in using these laboratory animals, what's our concern? We collect blood from them, either for production of a reagent or probably for testing a drug. For instance, if you produce a drug, if you want to know the lethal dose of that drug, what the biochemists will refer to as LD50, you're going to use the mice to do that. And you check a dose that kills about 50% of the mice, that tells you that that dose is poisonous, both for a human being. And so you now know where to niche that, okay, look, this human being needs 500 milligram of paracetamol, or this adult needs 1000 milligram of paracetamol. Remember our common paracetamol that takes care of headache. If you abuse it, it destroys our liver. Yes. So it is through using laboratory animals to do such experiment that they know that what is ideal for a human being is 1000 milligram. And you take it for a maximum of about 3 days. If you have fever or weakness that continues, please go to the hospital and find out why you are having those. But science came up with that with the use of what? Laboratory animals. So for you to use them for experiments, you need to do blood collection. You can either collect blood through the submandibular venipuncture, that's somewhat around here, middle. This is your jaw, between the ear of the animal and the lower jaw. You try to collect your blood. Some people can use a tail snip. You just try to cut the tail a little and you now collect blood in your EDTA container. You can use the jugular vein, this vein that is here. If you touch this place, you will notice that there's something pulsating. That's the jugular vein. You can collect blood from the jugular vein. For the rabbit, you can touch their ear in a friendly manner. You are going to see their marginal ear vein. You can collect blood from the ear of a rabbit. Now, if you need a very large quantity of blood, then you can do the cardiosynthesis. That means you're going directly to the heart to collect blood. And to do that, you must first of all anesthetize the animal properly so that the animal does not feel pain. But whatever method you use for your blood collection, you must do analysis of that sample within 4 hours and not later than 24 hours. And then for blood collection in animals, you must be fast to collect and mix with your anticoagulant because their platelet number is great. So before you know it, you start having platelet clump. And eventually when you do the platelet count, you say that animal's platelet count is low. Meanwhile, blood clotting have taken place, and that gives you a wrong result. Now, in use of experimental animals for blood film and blood cell count, which we are concerned with, there are machines, just like you have machines that do full blood count for human beings, you have veterinary machines that do also full blood count for laboratory animals. And some of the examples are these I've listed: the Hisky, the EDEX. You also have the Advia 120. Those are veterinary machines that help us do full blood counts in laboratory animals. And the running of this machine are the same with that of human. Like the Hesky machine uses the electrical impedance method, just like our human machine, while the EDEX uses the flow cytometry, just like the human. Is the same thing. So in running them, you must first of all run your quality control sample. You must also do your what? Your startup, and make sure that your machine is working properly before you run the animal sample. But then, full blood count for laboratory animals does not end with the machine. Like I told you, I said they have high platelets. And because they have high platelets, you'll be sure that clotting ensues fast in them. So that brings us to our blood film. Whatever you do, you must do a blood film for a blood sample of laboratory animal collected. And the previous speakers have talked about blood film. They've talked about making of blood film for laboratory animal and for human beings are simply the same. Use your clean grease-free slide, drop your blood sample, use a spreader and spread. Simply the same thing. And then you also stain using your Romanowski stain. That's your Leishman stain, your Wright Jamesha stain, or your Jamesha stain, whichever one you want to use. Now, the film reading proper, the blood cells of common laboratory animals, that's your mouse, rat, are not different from that of a human being. It's just that there are few variation or slight variation. Now, the RBC of laboratory animals like mouse, pig, rabbit, as you can see, are smaller in diameter than that of a human being. While the RBC of a fish is nucleated. But in humans, when we see nucleated RBC, it raises our antenna. But for fish, it's normal. While for these other laboratory animals, their red cells are not nucleated, but the only thing is that it is smaller in diameter. Now, for the white blood cells, next slide, please. For the white blood cells, they also have white blood cells like human beings. Next slide, let's go. So please go back to that thing, the previous slide, sorry. Now, you can see that both in humans, RBCs are more in number than the white blood cells. So you can see that those cells clustered all over the place that are small, small, small are your red blood cells for laboratory animals. This actually is coming from a mouse. This picture is from a mouse. Okay, next slide. Now, for the white blood cell, you can use the autoanalyzer, veterinary autoanalyzer to achieve that. But in the absence of that too, you can use your film. And how do you achieve that? If you make a film, count about 3 fields. Count the white blood cell in 3 fields. Get the average. Multiply that your average by 15,000. That gives you a rough number of your WBC. That's your total WBC for the laboratory animal that you are using. Now, next slide. Now, after that, you can do the differential white blood cell count. Now, contrary to the human beings, in humans, we have more of neutrophils. Neutrophil between 50 to 70% is found in humans, while our lymphocyte is about 25 to 40%. But the reverse is what you see in animals. Typically, I used the mice because in pharmaceuticals, where they test drugs that are given to human beings, what the pharmaceutical industry use mostly is the mice. So I had to really for the mouse, the mast cell, you have a kind of rim. That's just the difference, but it's almost the same with that of the human being. Next slide, please. Okay, so now the platelets. The platelets, we know them that they have a short lifespan. Even in human beings, lifespan of platelets in mice is approximately 5 days and can be shorter in some other species. Now, veterinary analyzers often underestimate platelet counts, and reason is because of the propensity for platelets to clump. In fact, this I had to write that machine, the Advia 120, counts platelet clump as eosinophil, which is a very great error, and that brings you back to doing a blood film for your laboratory animal. Now, other facts to know about animal platelets is that platelet count, you do it in at least 5 fields. Get the average of that 5 fields and multiply this average number either with 10,000 or 15,000. It gives you a rough estimate of what the platelet count for that animal should be. Next slide, please. Okay, so mice have very high platelet count. That's 900,000 to about 1.6 million, against what you have in humans. Humans, our range is between 150 to 400, like we have in the textbook. But then, if you try to set that reference range for your lab within Africa, we discover that 100,000 to 400,000 is normal for Africans. So you can see that this is way above. So while you are collecting, you must do your collection fast, and you must mix with an anticoagulant by gentle turning, also very fast. If not, the platelets will all clump, and you will say that the animal has thrombocytopenia for whatever observation you are making. We say platelet activation in mice can be spontaneous and strain dependent. Some are much faster than the others. Next slide, please. Okay, so in conclusion, I want to say that having looked at this, man is just a higher animal, and there are no much difference between our blood cells and that of the laboratory animals. So basically getting the skills to be able to read a human film is a great tool for being able to read laboratory animal film. Thank you for listening. No, you didn't do this clap well, oh. So let's do it again. Atama, La Parena.
So, that's interesting. Thank you very much, ma, for the wonderful presentation. When she was stepping down to this room, I know she was going to do justice to her lecture. You know, so it was, they will say it's not, it's the spirit that revealed it to you, not by my power. I knew you are going to do a good job. Okay, now is our time. The listeners, the audience, now is our time to ask questions. Dear students, I hope you've jotted down questions to ask. Hello, you have your questions to ask? Do you have any questions to ask? Okay, so it's time for questions. We are taking as much as possible. And I'll be the one person to ask questions. And the question, I will throw it open to anybody who can give me a befitting answer. Filmmakers deal with film. Radiologists, they also deal with films. And I hear you people talk about film. Which film are you, how can you differentiate between these three films? You get my question? Filmmakers, movie actors, they act films. No be so? Na film na. Radiologists, you go there, you go to do x-ray, you collect film. Am I not right? And you guys are also talking about film. So who is acting the right film? You want to answer the question? Correct. I believe you.
Hello, colleagues. We are the people acting the real film. Ask me why. Because we copy from the original. Hello, we copy from the original. We don't need carry video thing to look at something. No, 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 no. We paint. Our own film is by painting. Hello.
Follow-up question. I'm still, if you have a question, please raise your hand up. When you copy from the original, when I go to do a scan, I am original. And I go to do a scan, I do not copy from original.
They don't copy from original. They only snap original. They snap it.
A round of applause for this woman. Madam, thank you. So those people acting film in the television, their own, you don't even know what they're doing. Imitation of life. Kai. Interesting. Who has a question to ask, please? Okay.
Thank you, sir, for this great privilege. I just have a simple question. When during the introduction, they said something about 17% of clinical decisions and diagnoses are supported by the laboratory scientists. My question is, how come it is not noticed, but all they just said is that the doctor have diagnosed the problem, but yet it's not noticed by the patient that it is the laboratory scientist that actually did more of the work.
Now, we have a slogan in medical laboratory science, and that is that medical laboratory science is the bedrock of medicine, of modern medicine. The truth is that why a patient comes into the clinic, as the doctor is asking you questions, he's making a provisional diagnosis, or what we refer to as a working diagnosis. Now, if you come and tell me that you are having pain, chest pain, now ordinarily what comes to your mind is that there's something wrong with your heart, is it not? But when you tell that to a medical doctor, we know that most of the pain people complain as chest pain are coming from the GIT, the gastrointestinal tract. So he begins to ask you questions within that area and he makes a working diagnosis. Now, to rule out and to rule in, that's where the medical laboratory scientist would come in. So part of the helping to rule out is that this doctor might place you to go and do an abdominopelvic scan, a scan of the abdomen. He will tell you to go and do what's this test that previously people don't, you don't take a blood tablet and all that, what do you call it, use stool to do FOB, fecal occurred blood, and he's going to write test and test like that for you. By the time those results come, he already has a working diagnosis, things he wants to rule in and things he wants to remove, that no, this is not the cause of the pain. By the time the scan result comes in, the fecal occurred blood test comes in, the stool analysis and culture comes in, probably chest x-ray, will also, you'll be sent to come, he can now say, okay, this chest pain is not coming from the heart. There's nothing wrong with the heart. And then they do fecal occult blood test is possible or positive. Okay, we can be querying that, look, there is what? An ulcer. The person can further send you for H. pylori. It's now helping him to rule in what is causing the ulcer, and he can begin to treat from there. So definitely the doctor needs the laboratory, and both the radiologist or radiographers and other people to be able to tie down his diagnosis accurately. Are you okay? Or you still want to ask some more questions?
I think he has. Your question is, why are they not noticed? When you guys are doing all this job, right? When the lab scientists are doing all this job, but they are not noticed by the patient. That's your problem now. You want to be noticed? Somebody wants to say something. I will cut you. I'll cut you.
We, in the first place, are the doctors that patients don't see. Are you okay? Have this one at the back of your mind. You are the doctor that a patient don't see. And I want you also to see yourself. I'm answering you now. Like me now, I'm an oracle. Hello, I'm an oracle of hematology. As in, give me, I do my things with joy. You understand what I'm saying now? And I'll go and tell them, do like this, do like this, do like this. And they will follow my instruction quietly. So you are the oracle. Hello.
Hello. Are you a student? Thank you. So it's as simple as what you hear is true, but that is the politics in the health sector. Have it behind your mind. That is the politics in the health sector. You get it?
And to add to what every other person has said, you see in the hospital setting, the physician is the first point of call. So for that reason, and most times, we don't have an opportunity to see the patient when we are in the hospital. What we see is the sample. And because of a level of ignorance in our society, even when people take the sample to the lab, they don't understand that the people who do the job in the lab are different from the person who sent the sample to the lab. So when the diagnosis comes out, they just assume that, look, the doctor says I have ulcer, not knowing that it's the sample sent to the lab that says you have ulcer. So that is why, like she said, you are the oracle. And most times you know that even as you go to the native doctor, you don't see the face of the oracle. They hide behind the mask. So that is where you are. Thank you.
Well, there are so many reasons, and they have said it, but let me tell you why. Like he said, the medical scientist handles samples. It's like your dad and your mom. Your dad is going out in the morning and give you money, give your mom money to buy food and give you and buy things for you. You go out, you know the person that is giving you, at least as a baby. Maybe by the time you get up, go grow, you know that the money is coming from the dad actually. So the doctor is like your mom. He's the person you are seeing. The nurse is like your mom. She's the person you are seeing. The pharmacy are the person you are seeing. But the person, the hand behind the mask is the medical lab scientist. It's natural. There's actually nothing wrong in that. That is the nature. Then, like somebody said, the politics of the health sector magnifies it so much to project some people and then to bring other people, so that you don't, because when you know where your power is coming, you might end up leaving the people you are seeing to go to the ones you are not seeing. Thank you.
Please, a round of applause. I'm sure you are cool with it. Okay, so maybe can I summarize this explanation by saying that when you come to you're having a meeting, you have the agenda, right? You have the agenda for the meeting, isn't it? So, medical lab sciences, the matters arising. That matters arising. Where did they treat for that meeting? The main thing. See, I'm not a medical personnel, but I'm sure I said it before now that you can't talk about diagnosis. I mean, you can't go to a hospital without diagnosing what is wrong with you. So, and then I think you guys do more of a charity. Would I say use the word charity? When you're doing charity work, you won't be noticed. Okay, if you're somebody you want like all these crazy guys that will be giving somebody money and they will be videoing it, they're not doing charity. They're doing show. They want to drive traffic on their this. But when you are doing charity, nobody hears that. Only you and your God know say na so the charity be. So the point is, don't care, don't bother about whether they're seeing it or not. Do the job for the sake of humanity. Thank you.
So, I have a question. Though, just before I ask my question, you know, we have not been trained because we don't consult a patient. We don't consult. That's why in our lab form, we have clinical history or provisional diagnosis. So it's not you as a medical scientist that you put that, it's a doctor that will do that. So you are, whether you have, whether you are known to the patient or you are not known, that one is none of your business. You can only know the patient when the patient comes to the lab and collect what? Sample. That is all. Ma, I have a question. The last presenter. I have a question, though the question I'm going to ask is a little bit far from what you have presented, but I think maybe you will help me. Because I carry out some work on that is genotype and blood grouping on different species of rabbit using this common antiserum and also using genotype machine. But I discovered that at the end of my research, because what informed me to carry out that research, because I believe rabbits, they have red blood cells, we humans, we have red blood cells. So I decided to carry out that work. But when I used those antiserum, the result was that there was no group. All the result was group O negative. And the genotype, it neither showed me AA or AAS or SS. So, but I don't, because from your presentation, I believe that you are a veterinary doctor, if I can guess. Eh? Okay, she's not. Okay. Okay, now I thought he's a medical doctor, a veterinary doctor. But if somebody can help, because the way she presented, I thought she will be able to answer me. So thank you very much.
Okay. At this point in time, I'm going to call on, I think we are coming to the end of this program. Please, acting dean, sir, it's time for you to give other announcements. Thank you.
Thank you very much. I wish to appreciate all participants for staying this far. Tomorrow is day 2 and Friday is the last day. Tomorrow is paper presentation and also some of the topics that we presented. We will start by 10 Even though it's one person, I will start. But now we are waiting for nobody. So we have had to. So tomorrow is very apt. If you have laptop, come with it because of the application of AI in film reading. You likely get a software that will aid you. And you know tomorrow we are looking at how to read bone marrow film and other vital topics. So if you come by 8, if you come by that 10, by 2 we are done, including the paper presentation. So let's keep to time. Then on Friday, which is the last day, is hands-on. So I want to appeal to the HODs that if you know your department will present or will project such, try and get the blood samples, try and get the urine samples and all that, so that it will be seamless. Aside from that, try and check on their microscopes to make sure that all the microscopes are working. Now we have digital microscopes in hematology, micro and histopathology, and we are going to leverage majorly on those microscopes. So please set up your microscope. So you can come earlier tomorrow by 8 you are in the lab to set up the microscope. If you need power, I'll call the power department to put on the gene early so that you can set it up. The main program is Friday, which is hands-on, where you are going to learn how to read film. And I want to appeal to MLS Love Disability. If he can get us a live sample of film slide, it will also help us. Because you are presenting on it. But if we can have a live bone marrow slide that we can view on Friday, it will definitely spur up our challenge to go into bone marrow film reading. So thank you very much for coming, especially our colleague from Osogbo, coming from far away Osun State to participate. That tells us that our workshop is growing. And by this time next year, when we organize the second edition, it will be far, far better. From Plateau to us, thank you very much. Which hospital in Plateau? Which hospital in Plateau? Which hospital in Plateau? Okay, yeah, boom. Thank you very much. I have a lot of friends there. Potts is my very good friend. I think there was once I went to Plateau State Specialist Hospital when we did a program there. You are highly welcome. All our participants from other states, you will join us in a dinner tonight. So please just after the group picture, we're going to disengage from there. So let me call on histopathology HOD to lead us in closing prayer. Thank you very much. He's closest to God among all of us here. So God will listen to his prayer better.
We are God's children. Ladies and gentlemen, let us pray. In Jesus' name. Our precious Father, once again, we thank you. We glorify your name. Lord, thank you for the manner and the way you lead us today. The glory and honor comes to your name in the name of Jesus. Thank you, Father, as we're about to leave here to our various destinations. We'll get home and praising your name. And by tomorrow, by the grace of God, as my distinct dean have said, Lord, help us that we can be here by 10 tomorrow and start the journey of the film reading. And at the end, your name will be glorified in Jesus' name. In Jesus' mighty name I pray.
I appreciate you, D, my good friend, for doing a pro bono job for us. Thank you very much.